My name is Ballad Health. I want to say thank you for you that are on Facebook Live for tuning in. Thank you to the media for being here today. Especially want to say thank you to our team members and all of our facilities that are on the front lines taking care of our patients. They're working extraordinarily hard right now. And as we'll show in just a moment, we're seeing a very steep increase in number of inpatients across our system. And just want to say thank you to our team members for all the great work that they do every single day. So I'll share with you first the patient slide that we have. So this is our scorecard. As you know, that we send out daily. We're seeing still an unvaccinated number of people around 47 to 48%, so relatively low there. In the past 7 days, we've seen a real steep increase in our positivity rate, almost 45% now, in positivity of the patients that we are testing. Unfortunately, we've seen 73 deaths also in the last 7 days. In the hospital today, we did set a new record for the number of patients that are admitted with COVID-19. We have 436. We had yesterday was our previous record, and then back in September we had 413. So this current surge has really surpassed anything that we have seen before. We have 78 patients in the intensive care unit, and we have 55 patients on ventilators. We also have 8 patients now in Nice Lumber Children's Hospital with COVID-19. Go to the next slide. Thank you. So of those hospitalized, 436 people that are hospitalized with COVID-19, 86% of those have not been vaccinated. And if you look at the patients that are in the intensive care unit, 92% have not been vaccinated. And of those on ventilators, 96% have not been vaccinated. So obviously we are concerned about the numbers that we're seeing. The Omicron variant has had just a huge impact most recently on our region. And that's very evident by just seeing the number of cases and the number of new patients that we're seeing in the hospital on a daily basis. Just a moment, I want to share with you some more of our data, but as I just said, our new number today for inpatients is 436. Our positivity rate is at 45%, and that data continues to put a very large strain on our system, and we'll be sharing more information about that impact in just a moment. So let me go ahead and share with you the data pack that we normally share. So unfortunately, as you can see, this past week, January the 16th to the 22nd, we had 15,421 new cases across the region. Prior week was 12,309. You can see back in September when we had our most recent surge, so we're almost double what our surge was from back in September. And then you see the prior surge last year was at 5,000. So it's a very large number of cases, and we've heard comments that maybe Omicron is not as severe, but when you have this many positive cases, that's going to cause more and more admissions across the region. So obviously we're very concerned about that. So again, this shows the census this past week especially. We've seen a steep increase in the number of patients in-house. Of the patients that are in-house today, almost half are between the ages of 40 and 69 years of age. The average hospitalized patient age is 64, almost 65 years of age. The vaccinated patient is right at 73 years of age, and the unvaccinated average age is 63, almost 64 years of age. Go to the next one, Zach. So this is comparing the surges from the previous 2.5 years we've been tracking this. So you can see compared to a year ago, kind of where we were, back where we were back in September of this past year. And we peaked back in September 8th at 413, as you see right there. And then our current peak is now in a new record at 436. You remember that first surge that we had, we started to see a decrease, and I'll show you a comparison of the two surges here in just a moment. So this shows year over year our census for inpatients. You can see almost a year ago where we intersected right here in early January. If you remember a year ago, that's when we really started to be able to distribute vaccines across our region. And with the variant that was there, it had a huge impact in the number of people who did not have to be admitted to the hospital. So that vaccine back in a year ago made a huge impact on our admissions. you can see now, we're still seeing a pretty large increase compared to where we were this time last year. Then, as I said, our positivity rate now is almost at 45%, 44.7. Comparing that to the average across the state of Tennessee, which is 41.2, and almost double what we're seeing across the Commonwealth of Virginia at 27.2. So again, a pretty steep increase across our region. And then our Safe at Home program, I cannot say enough about that. That's been just a great program where we monitor patients at home utilizing thermometer, pulse oximeter. We have interviews with those patients at home to understand how they're feeling and really are they getting worse, are they getting better, and so forth, and then give them instructions on how to proceed. And so we were able to keep more people at home that way. Today we have 297 people being cared for in the Safe at Home program. And then we've talked a lot about monoclonal antibodies. At this time, I want to ask Dr. Mark Wilkinson, who's our Chief Medical Information Officer, to talk a bit about this, especially since we're seeing such a decline in the administration of that. So, Dr. Wilkinson.
Thank you, Eric. So, I think you all know that we've used monoclonal antibodies now for several months when they became available to the healthcare system. And we've relied on two types of antibodies for infusion for COVID-positive patients. Those were provided under an emergency use authorization from the government, from the FDA, and we could use those to help prevent severe illness in those that are COVID positive. And so those two types of antibody cocktails were effective against the Delta variant, and you can see utilization for those antibodies were spiking here in August, September, then also through the holidays here through Christmas time. Unfortunately, the Omicron variant is not responsive to the two types of monoclonal antibody combinations we've used historically. As a result, the FDA has withdrawn that EUA for those two types of antibodies, and so they only have one now available to us, sotrovimab, to administer these patients with Omicron. Unfortunately, the sotrovimab is in short supply, so our supplies are extremely limited, and hence you see a drop-off from 286 units of monoclonal antibody administered about 3 weeks ago to less than, well, about 50 doses a week now for the past 2 weeks. As of about 10 days ago, we only had 50 doses available across all of Ballad Health for the entire region. And so we've had to be good stewards of that resource. Obviously, we've had to institute the NIH tiered standards for administration of those antibodies to those at higher risk. And so that's why we've seen a decline here, because of the supply available to us and because of the need to institute that NIH tiered approach to administration of monoclonal antibodies.
Thank you, Dr. Wilkinson. Appreciate that. So this is just a view to show you the inpatients, the patients that we have being tracked by Safe at Home. So 436 and those 300 being tracked through Safe at Home. So almost 800 patients being tracked across our region today because of that. I think we've got, okay, so our vaccination rate, unfortunately, as I said earlier, we've not seen a huge increase there. Across our service area, the vaccination rate is at 47.8%. And you can see, compared that to Tennessee and Virginia, we're lagging both of those states. Booster also almost at 40%, but still well behind the state, and right fairly close to Virginia's statewide average. So we're always concerned, and we have to speak about the deaths that we see as a result of COVID-19 across our region. So as of right now, with the deaths that we're experiencing, about a third of the deaths in our facilities is related to COVID-19. We typically do see a higher number of deaths this time of year, but especially strong with the number of COVID-19 patients we have in the house. And then our forecasting that we've done just a great job with this. It has helped us to prepare for some very high census. You can see the high, middle, and low. Unfortunately, we have actually peaked at our highest estimate today at 400 and sorry, off the number there, 436 is actually exceeds where our high number was expected for this time. So our estimates do show, our forecasting does show that over the coming week or so, we expect to see a decline in these. But again, this is just a forecast, and it really does depend on people being vaccinated, people being diligent about how to stay out of crowds and doing the things that we're seeing where this is spreading so rapidly. So that's where we are from a estimate standpoint right now. And you can see that this has had just a huge impact across our region. And it really has created a crisis state for our hospitals as well. And our frontline caregivers have tremendous stress today. They're working very, very hard to take care of our patients on a daily basis. And again, my thanks to all of them on the front lines. At this time, I want to introduce Levine, who is our chairman and CEO, to talk more about the impact this is having across our system. Alan.
I want to first of all say thank you and hello. And I want to thank Eric Eaton. I don't think people necessarily get to see the hard work he does every day on behalf of this region and all the team members that we have who rely on steady leadership. And Eric has done a remarkable job in very difficult circumstances. You know, Eric mentioned a few programs. Safe at Home is one in particular that we started back in November of 2020 for the purpose of trying to reduce the pressure on our staff. The more we could try to keep people at home, being properly monitored, connecting to them using the technology that we've invested so heavily in. To give you an idea of how effective that program has been, today we have 8 nurses monitoring 296 patients. If those patients were admitted to our hospitals today and assume typical staffing of maybe 1 to 5, 1 to 6, we would need 42 more nurses right now today just to take care of those patients. And so it's a very powerful indicator of how effective that program has been and how effective programs like the monoclonal antibodies have been, trying to do everything we can to reduce the demand on nursing. And you know, this crisis in staffing, which obviously existed before, but it's obviously become much more manifest since COVID began, doesn't just affect people with COVID. It affects everybody. It's frustrating and heartbreaking to see patients who go to the ER and wait hours upon hours before they can be treated. It's not that that's something we want to see happen. It's our nurses and doctors are prioritizing the best they can to take care of the people who are most acute and most at risk. We've been, I think, pretty transparent about this, and let me explain why this happens. When you are short-staffed with nursing, which is one of the most important indicators for how many patients you can take, when you're short-staffed on the patient care floors, there's a point beyond which the nursing leadership will determine it's no longer safe to bring more patients onto this floor, because we want to make sure we're taking good care of patients, and we don't want to stretch our nursing manpower so thin that they end up making mistakes. And so once that happens, once we hit that capacity on a patient care unit, we stop sending patients up from the emergency department, and they get held in the emergency department. And some things that have become a bigger issue for us, particularly with the growth in the Omicron variant, is that the labor shortage that we're experiencing is not just stopping here. Post-acute facilities, skilled nursing facilities, mental health facilities, they're experiencing labor shortages too. And when that happens, we can't discharge from our patient care floors to those post-acute facilities because they can't take the patients for the same reasons our nursing floors can't take patients from the emergency department. And you can see how this cascades throughout the system. When we can't discharge as many patients, more patients end up staying in the hospital longer, which ties up those beds, and then you can't get patients up from the emergency department. And who gets to feel the brunt of that? It's that emergency department patient that's sick and wants to be seen and treated, and they're waiting. And it is heartbreaking for our staff. And there's a point beyond which it becomes so dangerous that we have to do something different. And that's why we're as Eric pointed out, we have 436 patients in-house today. We have 834 team members today who are out at home with either they're COVID positive or they've been tested and they're waiting for the results. And that's about just under 7% of our total workforce. 79% of those team members who are at home with COVID are vaccinated. And it's a very confusing statistic. It's easy to conclude, well, then why get vaccinated? Because they're getting COVID. The vaccine may not and does not prevent the spread of this variant. I think we've all learned that. But what it does do is it mitigates the likelihood that you'll get admitted to the hospital or become very seriously ill. And so given that 79% of our employees who are at home with COVID are vaccinated, we're very thankful that they got vaccinated and are not now patients in the hospital. But with 834 team members out, and while we certainly don't speculate about our volumes, I think based on what Eric and I were looking at earlier today, again, not speculating, but I don't think that number is going to decline in the next few days. And in fact, it could get larger. So with that many team members out and the growth of inpatient cases with COVID that are now 30% of our total volume, nationally, about a quarter of patients in the hospitals have COVID. Here, it's a little above 30%. So it's evident that we're carrying a disproportionate burden. But the other part of this is there are so many other patients who need services that we have to take care of. It's our responsibility to take care of them. And one of the things we had done before, we've done it twice. First time it was imposed on us by the government. The second time we did it voluntarily was deferral of elective surgeries. And what we feel strongly about, having discussed it as a team, is that deferring elective surgeries is the last thing we want to do. The word elective seems to imply to some people that these are surgeries that aren't really necessary, but that's not true. These are patients, some of whom have cancer, some of whom have serious orthopedic injuries, including Eric. These are patients who need these procedures, that need this care. And so this time we've made a decision that we are not going to defer elective surgeries if we can avoid it. And so where does that leave us? Well, we've got to figure out how to get staff back to work. And so we've declared that we're in a crisis, we're in what we call crisis staffing. The CDC has given guidance to hospitals and health systems based on each system's assessment of where they are and what they need to be doing. By declaring crisis staffing, there's a few things that triggers for us. Number one, if an employee is at home, if they've tested positive with COVID, but they're asymptomatic, our expectation is that they will come back. And we will deploy those team members where appropriate to help support our clinical staff. If they're clinical, it's possible they can come back and work in a COVID unit. It's possible they can work in the emergency department as a sitter. When we have mental health holds, as I've mentioned, some of our hospitals, 20% or more of our ER visits on any given day could be mental health holds. And each of those requires a one-to-one sitter. And when we're using clinical staff to do that, it's obviously manifests in expanding and exacerbating our shortages. So team members who are at home who have tested positive but are asymptomatic, our expectation is that they will return, and our human resources department is making outreach to those team members now. Those who are symptomatic but whose symptoms have improved, we would invite them to come back and under the same set of circumstances. I will say that there are certain areas we will not permit them to work. I want to make it clear that they will not be able to work in places like our oncology units, our NICU, our birth and delivery, labor and delivery areas. Should actually have that list. Niswonger Children's Hospital or hospitals. So they will not be permitted to go to those areas. They will be required to, if they've been symptomatic and they've had a fever, they have to be without a fever, without any medical help. meaning if they're taking some kind of fever reducer, they have to be off that fever reducer for 24 hours without a fever before they can come back. So all of the things that we're putting in place are guided by the CDC in terms of best practice for how to bring people back who might have COVID or have had it and are on the route to recovery, because we need their help. There's a point beyond which, and I want to be clear too about something. You'll hear from public health officials that the best thing you can do if you've been exposed is get tested and quarantine yourself and not expose other people, particularly if you're not vaccinated. And if you have been exposed and tested positive, you should stay away from other people. And that's true. But what's also true is, as a hospital system that has to care for patients who are very sick, there's a point beyond which it becomes more risky to keep these people at home and not take care of the people that need help. And that's the point we're at. We believe we've hit that threshold, both in terms of volumes of patients here in the hospital, as well as those who are at home with COVID that are employed by Ballad. So what we're prioritizing today is the frontline delivery of healthcare without interrupting access to care. And that's what this is about. Just want to make sure I don't miss anything here. I talked about elective surgeries. There is some emerging study that we're watching with respect to, I think it's being done by anesthesiologists nationally, that looks at the impact on patients who are undergoing anesthesia who have COVID. There is some emerging science on that, and it is possible that if you're a patient that has COVID and are scheduled for surgery, it may be best for your surgery to be delayed for a period of time. That's purely driven by what is emerging clinical evidence. We'll be able to talk more about that as more data comes in. But if you have COVID and you need a surgical intervention that's not emergent, it may actually be in your best interest clinically to postpone that surgery. And we're working with our anesthesiologists and our medical leadership, physician leadership, to assimilate that data and then share it with physicians throughout the system so that they can make the best decisions between themselves and their patients. There will be some additional, there is some additional work that's being done, I think, internally. I think it's probably important to say that COVID could disappear tomorrow and the labor problem will not go away. There's going to be a tail effect of this labor issue that's going to last for some time. And so we're already beginning some internal discussions and strategizing about what we can do in terms of retention and rebuilding the pipeline. There's a lot of damage being done to hospitals all over the country right now because of these labor shortages, particularly in rural and non-urban communities. And if you look throughout Ballad, we have vacancies throughout the system. What's emerged now with so many people working from home, even in our non-clinical areas, we're now competing with places like Nashville and New York for talent because they can work from home. And so we might have people that live here who are taking jobs in Nashville or Atlanta or New York, and it's just it's a different landscape. What's emerging is a very different landscape. And so we're trying to develop strategies right now, even as we deal with this peak, we're beginning to think beyond this peak as to how we're going to recover from this. And I think the other thing that we're doing, Eric started a program called Helping Hands. We've taken some steps to defer many of our management priorities for this current year in order to free up time for management throughout the system to redeploy themselves within what's called the Helping Hands program. This program is designed for non-clinical people to go support clinical staff. So we've got, whether they're in our business offices or wherever, we're encouraging them. Right now we have over 200 volunteers in that program redeploying themselves to assist our clinical staff in the delivery of care. I think that program has been very successful, and I'm very grateful for the team members who have taken it upon themselves to volunteer for that. I think it needs to be said that, today is day one. Today is the deadline for the first vaccination under the new CMS mandate. Ballad made a decision, but because of the delays that occurred due to the court actions, we deferred implementing that until we found what the court was going to decide. And once we did that, once the court made their decision, we went ahead and established February 11th as our deadline for the first shot. So while the deadline is technically today, I think that what we're doing, we did for the purpose of making sure everyone who wanted to seek an exemption could do so. We're being obviously very liberal with our approvals of those exemptions, both for medical and religious reasons. And as it stands today, we have just under 1,000 employees who have not taken the vaccine and who have not sought an exemption. Obviously, we're very concerned about that. I think our opinion on the vaccine mandate is well established. We've sent comments to CMS on what our concerns are, and we made recommendations as to steps we think they could take to help. It seems quite illogical at a time where we're having to put crisis staffing in place to then turn around and ask 1,000 people to leave. That's something that we are loath to do, and we're going to do everything we can to encourage our team members to get vaccinated, recognizing that that this is a choice they have to make. But the way the rules are structured, Ballad Health has no choice but to have a policy that says, in order to work at Ballad or to interact with Ballad or any hospital in the country, you must be vaccinated with either the Moderna or the Pfizer or I think the J&J vaccine. I can't even imagine what it would look like to terminate 1,000 employees right now. Speaking for myself, I listened to the Supreme Court arguments from start to finish. I think there were comments made by some of the people arguing before the court that were not accurate. And so I do know that the cases are going to continue. All the Supreme Court did was defer or stay they wouldn't approve the stay of the implementation of the mandate, but those cases are still working their way through. It is one of the key critical CMS standards for conditions of participation is that hospitals provide safe levels of staffing for their patients. And now you have two conflicting provisions of conditions of participation. One that says you have to have safe levels of staffing, and the other that says you have to fire people who aren't vaccinated. Those two things conflict right now. And so I want to be clear about Ballad's position on this. We are going to do whatever we need to do to protect the safety of our patients and to make sure that we are adequately staffed to care for the needs of the people in this region. We will do everything we can to work with CMS as we try to comply with the vaccine mandate. We're not going to put our patients at risk, and that is our position. And with that, I'm gonna turn it over to Lisa Smithgall, who can talk a little bit about some very important matters related to our staffing, and then we'll be happy to answer any questions you have.
Thank you, Alan. And I'd like to start my comments today to thank every member of the frontline team at Ballad Health and for all of those supporting the frontline team behind the scenes. To thank them, you never give up. And even though we've seen many, many challenges, and no matter how hard and challenging it continues to get, you are there for our patients, and we appreciate that very much. You're truly embodying what it means to be a hero for our community. I went into nursing 39 years ago and have never in my career seen anything like this. And I know that many of our team members have not either. As our friend and local pastor, Alan Jesse, shared with us several months ago in one of these press briefings, the Bible says in Esther chapter 4, verse 14, you've come to your position for such a time as this. And this verse invokes courage and hope in me, and I pray that it does in you as well. From the bottom of my heart, thank you for your service during these very unprecedented times. As part of the nursing team, I can tell you firsthand that our teams have never stopped being impacted by this pandemic. We still have plenty of patients who need to be taken care of on a daily basis. And while it's true, as you heard already today, that vaccinated team members and individuals or those who have been previously infected with COVID-19 may experience milder symptoms with Omicron because of added immunity that they have, that's not the case for everyone, as evidenced by the number of people in our care. Omicron is spreading at a rate not seen in any of our COVID-19 variants prior to today. And as this virus makes its way into the unvaccinated population, many people are continuing to get very sick at a much faster rate. The rapid increase in infection within our community and now within our own team is causing serious strain on our ability to provide care. With more patients and fewer caregivers, our patient ratios are higher than normal, meaning every nurse is caring for more patients at one time. There simply aren't enough bedside caregivers available to handle this crisis in our and other hospitals across the nation. There isn't enough staffing capacity to admit additional patients onto our inpatient floors, which is causing those overcrowding and longer wait times in our emergency departments. Our teams are overwhelmed by patient volumes and care requirements during the pandemic. And while nursing shortages have long been a challenge in rural America, this pandemic is stretching our staff like we've never experienced before. The fight our frontline has waged since the start of the pandemic, nearly 2 years ago, cannot be overstated. Our teams are exhausted. They're sometimes working 4 and 5 consecutive 12-hour or longer shifts per day, with only 1 or 2 days off, which is not sufficient to give them recuperation time. Likewise, our nursing leaders are consistently working upwards of 7 days a week, many days staffing and providing patient care in addition to their leadership functions. They do this because they came to work in healthcare with a mission to serve and care for others. And they have more than fulfilled this mission time and time again. They've given everything up to be here for you and the families that they need to be caring for, and they need your help. So what we need from our community is support. We can't expect our team members to do this alone. While our entire health system is stepping up to help, we need the community to do so as well. And there are a number of ways that you can help. First, we ask for your grace and patience for our front line as they care for our communities during these extraordinary times. This extends to all our team members who are asked to share our visitation and masking guidelines with visitors for safety. These guidelines are in place to protect everyone in our facilities, and we ask that you be kind to our healthcare workers when they remind you of those actions. They're giving everything they have, and a little kindness does go a very long way. Our team members are doing everything they can to provide you with the best service and care. Please be understanding and respectful to them as they do their jobs. During these unprecedented and challenging times, we are all making sacrifices. Next, we ask that you help with slowing the spread of the infection and the burden it's causing on healthcare staffing and care. Having sufficient staffing is critical, as you've heard. It reduces the risk of compromised care, inferior clinical outcomes, and poor patient experience. If you haven't had the COVID-19 vaccine, please review the data and science behind its safety and efficacy. Getting vaccinated doesn't mean you won't get infected, but it will reduce potentially the severity of the disease and keep you out of the hospital and off a ventilator. Continue to follow precautions like masking and social distancing wherever you are interacting with others, including your family, your friends, and anyone around you. Avoid using the emergency room unless it is a life or limb-threatening emergency. If you're experiencing shortness of breath, chest pain, stroke symptoms, or other serious health emergencies, call 911 or go to the emergency room. If you're seeking care for non-emergent or routine healthcare needs, we ask that you reach out to your physician or go to an urgent care clinic. If you're a retired nurse, a respiratory therapist, LPN, or someone that wants to help in healthcare, we ask you to consider joining our team. Bringing retired caregivers on board into support roles helps us to free up bedside caregivers to focus on our increasing patient care needs. We want every person to receive the care they deserve when they need it, and it's going to take all of us to do that during this time of crisis. Thank you very much for your time. I'll turn it back over to Eric.
Lisa, thank you. We'll open it up for questions at this time. We also have Jamie Swift with us, our resident infection prevention specialist experts.
All right, 2 questions apiece. We'll start with Tim. Are you good?
Yeah.
Okay, all right, Ashley then?
Sure. So can you touch just a little bit more, this might be Alan, you talked about 1,000 employees right now not having the vaccine and that deadline is coming up. You said February 11th is the deadline for the first shot. Any extra communications going out to those staff members or any extra efforts, in effort to try and get that last population of employees vaccinated? And if that doesn't happen, will they be let go on February 11th?
So we're making several different types of attempts to communicate with the team members. One of the most effective mechanisms we have for communication is it comes directly from their managers and immediate supervisors. That's where the relationships are the best. And so we've been providing information to the managers and supervisors about their team members whom we have no documentation that they've been vaccinated or that they've requested an exemption. So yes, that data is being provided regularly to the managers and supervisors with the expectation that they're communicating with their staff. We have provided enormous data and information underscoring the safety and efficacy of these vaccines. The problem is people get their information from so many sources now. And I've always wondered why some people would prioritize information they get from anonymous people on social media before they would their own employer or physician. But nevertheless, that's what we're competing with. So we're just going to continue to keep trying and leaning into it so that we can get them to that point. I will tell you right now, as it stands, the way the requirement, the federal government requirement works, we have to have all of our team members have to have had their first shot by today. Technically, that puts us out of compliance because we still have 1,000 people that haven't been vaccinated. But we made a decision to postpone the deadline for a few weeks to give people more of an opportunity to apply for exemptions. And we're encouraging them, if they have a religious or medical reason, to certainly seek that. Now, here's the problem. Number one, a lot of team members, and this is true everywhere in the country, a lot of people say, well, I've had it, and so I have natural immunity. Why isn't that being recognized? That's a legitimate concern that they have. But the CMS regulation does not make account for that. Number two, in talking to some of our team members who are in a quandary, because it shouldn't surprise anybody here, culturally, we have a lot of people here who are of faith. And when I ask them, well, why won't you just seek a religious exemption? And I have to say, I really respect this answer. They say, well, I don't have a religious opposition to vaccines. I'm vaccinated for the flu. I comply with the flu vaccine. I comply with the MMR vaccine requirements. To say now that I have a religious opposition to this vaccine, this is what they say to me. I'm not going to hide behind my faith for something that isn't true. I'm just afraid. I'm just not ready for it at this point. And that's a legit. I mean, people really do feel that way, and I respect that. Unfortunately, the Medicare rule, the conditions of participation for our hospitals to participate in Medicare and Medicaid do not allow us any other provision. It's either a religious or medical exemption. So I will say I don't believe that CMS will be unreasonable in enforcement, but I do believe that if they don't see us actively trying to comply, then the penalties could be pretty severe. when you're in violation of the conditions of participation. So I don't want to speculate about what will happen on February 12th, but as the rule reads now, they're not permitted to work once that deadline has come and gone. So that's where we are today, and we'll just continue to lean in and communicate with our team members and beg them to consider staying here and working with us on this.
You would ask my second one now?
Yes.
Or you gonna- Talking about this surge being worse than previous surges, is Valley considering bringing in National Guard help or outside help as those measures have been taken in the past? Is that something that would be needed at this point, or something that is a part of the conversation to happen in the near future?
Hi, thank you for that question. Regarding National Guard, National Guard is only deployed and eligible to be employed in hospitals when an executive order exists from the governor, and we currently do not have an executive order in Tennessee. I know that we have requested in Virginia some support, but we don't have any answer to that question yet.
All right, David?
I want to talk about your forecast model. Eric, you said that you think, are we near the peak? Is that the expectation? And maybe it's going to start to decline, or what's the sense there over the next, say, week or two?
Yeah, the modeling shows that we're at or near the peak, that we think it could last up to another 7 days. We could continue to increase. So when we started reviewing the data again yesterday, we do think that that's going to continue. We think it could continue into the mid 400s for another week or so. We do think that our modeling has always shown that our peak is going to be end of January towards the early part of February. And so that's still where we are today.
Okay. And to follow up on the employees, if you've got 800 out because they're sick, and you've got 1,000 that may or may not be able to work, I mean, that sounds like an absolute total catastrophe for a healthcare system up front in a month from now, basically.
Well, we could have used you to testify before the Supreme Court. It is. Look, well, let me correct one thing you said. We have 834, 836 out who have tested positive. That doesn't mean they're sick. There's some there are many that are asymptomatic.
Okay.
So, because I don't want the public to think we're bringing sick people back in to the hospital to care for them. It's only if they're improving and therefore less likely to spread, or if they're asymptomatic and therefore less likely to spread the disease, along with all the PPE that we require they wear. It is catastrophic. If there weren't 800 people at home today and we had to fire 1,000 employees, that would be catastrophic. This is a rural health system. When you see national stories in the media about hospitals that implemented mandates and only 100 or 150 employees that had to be fired, well, those hospitals aren't in rural and non-urban communities. And I keep saying this, one of the big priorities of the current administration in Washington is equity. It's understanding cultural differences in the delivery of care. 85% of our country is rural. 85% of the landmass of this country is rural, and not respecting the cultural differences that exist in these communities, particularly as it relates to something like a mandate that you inject something into yourself that comes from the federal government, not understanding that there are cultural reasons why people recoil from that. And I testified to that before Congress. I've been very candid about that. Respecting, if you're looking for equity in healthcare, if you're looking to create cultural inclusion in healthcare, then that means respecting cultural differences. And you can't ignore that 85% of our country is rural and has a culture that's different than the culture that exists in New York or Boston. And so we're going to keep making that advocacy, and even as we try to make sure we're doing the things we have to do to comply. I also want to say it's really important to underscore. It's easy to. I've seen some comments where people are, critical of healthcare employees who won't get vaccinated. And look, I understand that, but at the end of the day, these are people too. And there's 40% of our region has gotten vaccinated, so close to 55, 60% of our region is not vaccinated. So therefore, it shouldn't surprise anybody that a similar percentage of healthcare employees might also not be vaccinated. Although I'll say 60% of our team members are vaccinated. So our vaccination rate's actually higher than the average in the region, which is positive, but everybody is not necessarily yet convinced. And that's just where we're at. These people, just because they've chosen not to be vaccinated, does not make them bad people, and it doesn't make them less valuable team members. It just means they're not vaccinated. And if they get sick, if they get infected by the virus, they're more likely to be hospitalized. You know, and that's where we're at.
Can I just follow up? Is this going forward in all 50 states? I know there was an exemption. There was 20 or 25 states it wasn't. What's the status of that right now?
25 states go into effect today,
Okay.
and the other 25 plus DC and Guam, I guess, or whatever the other territories, Puerto Rico, go into effect. They were delayed because they were part of the litigation,
right.
So it's a couple weeks. So I still think even with us going to February 11th, we're still within a window where I don't think there'd be any repercussions for that.
Thanks.
All right, Jonathan?
Yeah, I'm wondering what the confidence level is in the modeling that the number of hospitalizations will begin to plateau and start to decline. Data released from the state of Tennessee yesterday shows that cases are at an all-time high in our region, and they don't appear to be slowing down. I know that data is, a week old at this point. I'm wondering if you guys are seeing anything in your testing sites, testing centers that might indicate that cases are starting to slow down, and you can reasonably expect that a decline will happen soon.
Well, we saw about 4 days in a row where we had actually saw a decline. We were seeing somewhere around 800 or so positives a day. I think Jamie and our numbers that we were seeing, I think yesterday we hit almost 900 or maybe almost 1,000 yesterday. So that was kind of not what we expected from our testing out of yesterday. Our modeling historically has worked pretty well. We've been pretty close to it, and we're still pretty close within the range that we've shown here. But it is modeling, it is forecasting. It's like other forecasting that's being done elsewhere. We're using the very best data we can gain from the states, and so we still see, again, for the next week or so, we're going to continue to see a high number of inpatients, and we'll just continue to update that data as we can. But as of right now, we still feel relatively confident that our data is good, and we historically have had good information to base that on.
And as Lisa noted, without an executive order, obviously National Guard can't come and fly or provide some assistance to staffing. Have there been any conversations with the governor's office about potentially him issuing another executive order to allow that extra staffing?
No, we haven't explicitly asked for. We Ballad have not explicitly asked for an executive order. I know the Tennessee Hospital Association has had some dialogue with the Department of Health and the governor's office to determine what steps can be taken to provide some flexibility and support. As of now, there hasn't been anything communicated to us that there will be another executive order. And so that's kind of, again, Virginia has done one. Governor Youngkin did one last week. In fact, I have to say, there's a sort of a bright spot here for our region. In announcing his executive order, he actually highlighted the Ballad Health Safe at Home initiative as an example of innovation, which has helped reduce the need for hospitalizations and which has helped reduce the cost of all this, because there is no reimbursement for Safe at Home. These are people that could have been in the hospital, and Ballad could be billing and collecting for that, but instead we're doing everything we can to keep them out of the hospital, and it's not something that there's any way to bill and collect for it. It's just something we're doing to try to help reduce the load on our team members. But that was a little bit of a bright spot. I know that wasn't your question, but it was a little bit of a bright spot to have our region highlighted by the new governor of Virginia as something we're doing right.
Okay, thank you.
All right, let's move on to the line. Spencer with the Greenville Sun, are you still on?
I just have a question. So you mentioned all the people that are out right now, and all the people that could potentially, if they aren't exempt by February 11th. Most of those people, are they concentrated in certain facilities, or are they sort of spread out? Are certain facilities going to be hit harder with staffing issues out and in the coming weeks?
Yeah, so what we've seen is it's about 2/3 of those who are out are clinical or clinical support, direct clinical support, and it is spread throughout the system, but by far the largest numbers are at Johnson City Medical Center, Holston Valley, and Bristol, which could be expected because those are because they have a larger number of team members, and that's where the largest number of patients with COVID are being treated. So, but it is spread. I mean, we're seeing it throughout the system, and we are tracking that by hospital by day. The smaller rural hospitals are not quite as impacted, but again, in a small rural hospital, if you lose 3 or 4 people, that can make a big difference in staffing.
All right, Spencer, do you have another question?
Just to follow up there. So as far as the people that are unvaccinated so far, those 1,000 or so people, would those be spread across the system as well? And if there is a time where those people are terminated, is that going to put as large as Bristol or Holston in really tough positions?
Yeah, I would say that the question was that those who are not vaccinated, the nearly 1,000 people, are those spread throughout the system, and how does that affect some of the hospitals? Yeah, I think the broadest possible way to answer that is that it is throughout the system. Can't give you the exact numbers by hospital right this second, but it is spread throughout. And yes, it will have there's not a single hospital in our system that won't feel the effect of it if those employees were terminated. So I think everybody will feel the effect of that. Most importantly, our patients will feel the effect of it.
All right, thank you, Spencer. Next, we have Elizabeth with Radio Greenville. Elizabeth, are you still on the line? Elizabeth going once. I know a couple of people hung up. She might have been one of them. All right, we'll move on to Richard with Cumulus. Richard, do you have any questions?
Yeah, I have one. With this latest surge and with the ongoing supply chain issues that we see, how are y'all fixed on PPE supply this go around?
Yeah, Richard, this is Eric. We're still in very good condition from PPE. Our supply chain continues to do a great job at supplying that. And with the issues that Alan just discussed regarding crisis staffing, we're actually providing N95s to every team member to utilize, which is taking it up a notch from what we did before on a daily basis. So we actually have acquired more N95 masks to be utilized across our system. But we're in good condition. Our supply chain continues to do a great job of supplying our hospitals.
Do you have another question, Richard?
No, that's got it. Thank you.
All right, thank you. All right, next we have Jeff Keeling with WJHL. Jeff, are you still on the line? Jeff going once. Guess he was the other one. And then finally we have Vinay with the Knoxville WBIR. Vinay, do you have any questions?
Yeah, just one if I may.
Sure.
How much of the hospitalizations are people with COVID, and then are you seeing other respiratory issues at the hospitals as well?
Yeah, we'll ask Jamie Swift, our Chief Infection Prevention Officer, to answer that.
Okay, so the question was about how many are actually with COVID and other respiratory diseases. I can tell you that flu has gone down significantly. So we had a couple weeks that flu was very significant, and I was extremely concerned if it stayed on that trajectory. As far as with and for COVID, we continue to have that discussion, get asked that. We don't do admission testing on every single patient. So right now, the majority of those numbers that you see are admitted for COVID. We do find through pre-surgery testing, through people who may be incubating and test positive, we do have some of those incidentals that are admitted for something else. But right now, we are seeing the majority of those are still actually for COVID.
But I think, Jamie, I think the question, correct me if I'm wrong,
RSV.
Are you saying other respiratory conditions like RSV and other stuff like that?
And RSV is down, like I said, flu is down, so we still have those winter diseases, absolutely. We're still gonna see parainfluenza, we're still gonna see admissions for flu, we're still gonna see RSV, especially in the pediatric. So all of those normal winter diseases are still in place. They're not as bad as they have been in weeks past, but certainly we're still in respiratory disease season. We'll still see COPD admissions. We'll still see several admissions for multiple respiratory diseases.
Okay. Do you have any other questions, Vinay?
Nope, that's it. Thank you.
Awesome, thank you. All right, any other media on the line? All right, then that concludes today's presser. Thank you.
Thank you, guys.